Hi, hi friends. Thank you for taking time in a valuable weekend for attending the Cholesterol Code movie that we had the pleasure of seeing. And before we start, I want to be fully transparent. The Keto CTA paper that many people have been discussing that has been retracted, but I'm not presenting this as a settled science, but what I'm saying is science is a process, not a creed. So we should be able to hold both truths together. The first being ApoB containing particles matter in atherosclerosis. The second being human physiology, plaque biology, metabolic context, and the individual response to more nuanced. There are more nuance than a slogan. So whether the slogan is lower is always better or LDL doesn't matter, my goal today is to not just preach rebellion against medicine, is to ask better questions, interpret evidence carefully, and keep the patient's care anchored in humility, rigor, and respect. So I have the pleasure of having Dr. Ali here. And Dr. Ali, can you give an opening statement on the movie? And obviously you were partly involved in the process too. But before that, please give an introduction about you, and then let's then go around the room and give everybody an opportunity to introduce themselves, then ask a question.
Well, thank you, Ravi. Thank you for getting the movie available to so many people from India and in the US. I know that you had to put in a lot of your personal funds to do that. I am an interventional cardiologist. I've been practicing low-carb cardiology, not just for myself, but for a large group of my patients since 2013. So I have about roughly 12 to 13 years of experience in this field. I don't want to elaborate too much about my background. I am from India, from Hyderabad, and I want to give people an opportunity to ask what they have, questions that they have, and together as a group, we can see whether we could solve them or come to some kind of a resolution. Yeah. The movie done by Dave Feldman is extremely good because it talks about the broad scope of metabolic ill health in a larger global population and how metabolic ill health not only affects cardiac disease, but affects mental disease, affects every different type of inflammatory disease, even things like Crohn's disease, other inflammatory bowel disorders. So mental health, metabolic health, all the chronic diseases, including malignancy, are intricately tied. And like Ravi will say, even wound care is intricately tied to the lipoprotein profile and to metabolic health. So this is an intersection that doesn't just affect cardiologists, it affects every single human on this planet. So with that, maybe we can give an opportunity to people to chime in and give us their thoughts or their concerns.
Yeah, please, one at a time, you can unmute yourself and ask questions, and we're here to answer as much as we can. Thank you very much. Please go ahead. Who wants to start first?
Can I open, Ravi? This is Dr.
Yeah, Ashish, please go ahead. Open, and you can unmute and also show and come on the camera too.
Okay, I don't know whether I will come on, but at least I can speak.
Yeah, so please, we are able to hear you.
Dr. Nadir and Dr. Ravi, I've been following both of you. Dr. Nadir's videos I've been seeing since last few years. I am myself a gastroenterologist based in India, and I've been practicing preventive medicine for all my patients related to fatty liver or otherwise using the diet and exercise. Now, my question was regarding the lean mass hyperresponders or the study they conducted or the video movie that has been presented, whether this theory can be applied to all the healthy population, or this is for a specific group of people? What do you feel? Can we generalize this LDL, increase levels of LDL, ignore them that this is only for a particular group of people, or we think this should be applicable to all the people who are healthy?
You want me to take that, Ravi,
Yeah,
or
please,
you want to
please,
address?
please. You're the expert here.
So your question is, and for those of the people who couldn't hear it, the question is that
International meeting.
this high elevation in LDL and this diet can apply to everybody, or is it something that is more nuanced? And the answer, of course, is that it is definitely a lot more nuanced than saying that every single individual can go on a low-carb diet, that their LDL will go up, that their HDL will go up, that their triglycerides will come down, they'll become metabolically healthy. This doesn't happen in everyone. So it is a lot more nuanced than that. And if you are significantly metabolically unhealthy, so let me take two spectrums so that I can put some clarity onto it. So number one metabolic spectrum is somebody who is significantly obese, is insulin resistant, which means that their insulin levels are significantly high, their HOMA-IR is high, that they are either pre-diabetic or diabetic, that their triglycerides are high.
That sounds like another.
So if this is the kind of a person that you're dealing with, going on a low-carb, high-fat, standard low-carb diet can be potentially very harmful to you. And the reason for that is because these people are not able to process the fat. So the high triglycerides is a marker that your fat cells are very unhealthy. And the fat that you eat will not be picked up by the fat cells. It will be left in the bloodstream. And that fat then tries to find a location, an ectopic location to deposit itself. So it can get into your liver, cause hepatic steatosis or fatty liver disease. It can get into the pancreas, affect the quality of your pancreas and make your diabetes worse. And it can get into the blood vessels and promote atherosclerosis. So a person like that should not start with a high-fat diet. That person should focus more on a low-carb, low-fat, high-protein diet with fasting and physical exercise to first improve the health of their fat cells. On the other hand, if you're young, you're physically fit, your triglycerides are not high, your HDL is reasonable, then that person can start on a low-carb, high-fat diet and see significant improvements right away, because with the absence of carbs, the insulin levels drop. The fat that you're eating gets rapidly packed into the fat cells. You have jacked up the fat metabolism in the sense that you are doing lipolysis, you're making free fatty acids. These are being picked up by the liver, your ketone levels are going up, and your triglyceride levels go down because you're mobilizing and using the fat. So that person can go on a low-carb diet. So it's not like you would say that every single individual that comes into your office, you'd say, hey, start this low-carb, high-fat diet, and it's going to be uniformly good for you. I don't know if that answers your question, Ashish, but I'm happy to clarify any other points.
Can I ask a second point to the question I asked previously? Can I ask again?
Go ahead.
I was asking. I was wondering whether this increased LDL which occurs, specifically the increased LDL which occurs, is it safe for all the group of people, or is it not safe for all group of people?
So you are coming from a standpoint of LDL being causal in vascular disease. Is that correct, Ashish? That you're asking about?
That is the opinion of so many people, not me specifically. But
no, that is the. I'm sorry to speak in between, but Yeah, that's the 99.99 percentile opinion that LDL is causal in heart disease and dropping LDL is important. In fact, yeah, if you don't answer the question that way, you will fail in the boards and you would be an outcast from the medical profession to a large degree. So yes, that is the predominant opinion, but is the science settled? And I don't think the science is settled by any means, because there are alternative explanations as to what a high LDL means and its context with relationship to vascular disease. So for example, let me turn that around to you and tell you that the elevation of LDL and its presence in vascular tissue is not as an arsonist. An arsonist is the one who lights the fire and breaks things down. LDL is viewed as a molecule that gets into the subendothelium. It incites a plaque. That plaque builds up and grows. It attracts macrophages. It creates the soft plaque in the beginning, which later calcifies. So that's the predominant view. What if you change that paradigm and you say that the LDL is responding to an injury, whether the injury is from inflammation, whether it's from hypertension, or whether it's from severely uncontrolled diabetes. So LDL is responding to that inflammation in order to dampen the inflammation. And so it is a firefighter and not an arsonist. So this is a raging debate. And if you're really interested in dissecting this in some detail, I would recommend that you go to YouTube and Google me and write whether oxidized LDL is an arsonist or a firefighter. Then I go into the exquisite detail with regards to how LDL behaves, how it gets oxidized, how is the oxidized LDL picked up and dealt differently than regular LDL by the body. So that might give you a part of the answer. But for anybody to claim that this is a settled science and they know all the details, I think that's a little too premature.
Yeah, from my standpoint, I think, Ashish, this is a good question, and trying to understand what happens is in the process of what you do as a gastroenterologist. The disease process is simple. With this, my concept of disease triangles, which I have in my Zoom background. You see the basics is genetics, the left top is environment, the right top is lifestyle. So in social preventive medicine in India, when we are taught that this is why the disease happens. But in reality, the real process is happening when your environment and your lifestyle then influences your immune system and your lipid system, changes your microbes and microbiome, and connects the genes and epigenetics. So this is a concept of disease triangles that interacts every aspect of chronic diseases. And particularly, you know that with all the microbiome changes with the gut and GI problems, you know that the issue is how then the fatty liver problems happen, how the diarrhea for C. diff happens, and everything is connected. And obviously, like it's atherosclerosis affects every part of the body. Endothelial cells are there in all the blood supplies wherever the blood supply is. So nitric oxide production, endothelial lining problem, and the barriers between microbes and the gut, and the barriers between the microbes on the skin and the rest of the organs, barriers between the microbes and the brain are very, very protected. So when the barrier is broken, that's where we go into sepsis, infection. And when the sepsis and infection happens, the real problem is where the LDL comes in to take care of the problem to in a lipoprotein, it takes a process where lipoprotein has the cholesterol and triglyceride. The energy in the triglyceride used to bring it there, and the cholesterol is like a spackle that comes in there. Now LDL does consumed, but now like a EMS person, the immune system is going to come to take off things. So possibly the EMS would be the lipid system, and immune system would be the firefighters coming to clean up the thing. So this whole process without LDL, I think atherosclerosis is not going to happen. But what are the other factors? Where is the lifestyle? Where is the environment? Where is the immune system and lipid system not being factors? Because we are in this whole system where we interact and we are not one thing or another. So that said, please go ahead. I will stop here. And unless you have any other question, we'll take next person. Who wants to go ahead with the next question?
Dr. Nadir, I just wanted to add on to this. So would you differentiate statin use or LDL behavior in a person who is metabolically unhealthy versus who is not metabolically unhealthy or is perfectly fine? Like you've mentioned, LDL is a firefighter. Would you like to reduce the number of firefighters in a patient who is metabolically unhealthy, or you will just treat both the same?
That's a very good question, Ashish. So if I can rephrase your question, you're asking whether LDL and lipid-lowering drugs should be considered in metabolically unhealthy people, and perhaps optional in people who are metabolically healthy. In other words, like a lean mass hyperresponder who has high HDL, low triglycerides, high LDL, but low insulin, low inflammation. So I would say that the way I reconcile my answer is that I talk about the data from about 4 different standpoints. So number one would be, I would say there are so many trials on lipid lowering, and I say, okay, let's analyze the degree of benefit. What is the benefit of taking an LDL lowering drug? The second thing that I talk about is the conflict of interest. How was that data obtained? How reliable it is? The third thing that I talk about is what are the potential downsides of taking a statin? And the fourth one would be to talk about your bias. So all of us are biased. All of us are looking at incomplete data, and we have to make certain decisions based on a knowledge that is ever evolving and giving us new information. So let's go through all of that. So let's take a metabolically unhealthy person, and let's even say that they've had a previous cardiac event, like they've had a stent or they've had coronary artery bypass surgery. So the biggest benefit from any trial in this group of patients comes from a trial that was done in 1994, which is called the 4S trial, the Scandinavian study. It was done by Merck. Merck gathered all the data. They had the biostatisticians, they wrote the study, and so there is a significant degree of conflict of interest. So we would say there is some conflict. But let's say that this company and the group of investigators were scientifically ethical and robust. The data shows that for an endpoint of mortality from that study, and by the way, that study showed the biggest benefit, which has never ever been replicated in any other study subsequently. So if you took 100 patients in whom you're trying to do secondary prevention, based on the results of the 4S trial, which is the best trial that is there, 99.4 people treated for a year will have no mortality benefit. 0.6% of people will have mortality benefit. So I don't know how impressive that is to you, because I'm talking to you about absolute reduction. if you took a combined endpoint in which you included myocardial infarctions, the benefit would be that 1 out of 100 would benefit, 99 would not benefit. So the patient should know, or the person to whom you're prescribing this drug should know what they are getting into, because many people start this drug in their 30s and 40s and can be on these medications for 50 plus years. Now, let's get to the downside. What are the downsides of taking a statin? So as you know, statin block cholesterol production at the fourth step in cholesterol, fourth or fifth step in cholesterol synthesis, which is at HMG-CoA reductase. And if you take them through the pathway for cholesterol synthesis, there are about 25 different enzymatic steps through which you make cholesterol. So when you when you reduce making cholesterol, you may reduce all the intermediates also, and the intermediates have a lot of significant metabolic value. So treatment of people with statins has shown that you increase the risks of diabetes. The reason for that is that insulin receptor is processed by several of the intermediates in the cholesterol synthetic pathway. The second aspect is that the insulin receptor sits in a part of cell membrane that is very lipid rich. These are called lipid rafts. So you disrupt the orientation of the lipid rafts, so the insulin receptor does not function well. The third aspect is that when you start taking a statin, the liver gets a little worried because the liver cannot make any cholesterol anymore. And so it says, hey, I am not able to make cholesterol and I need cholesterol. So I'm going to start to pick up the cholesterol that is there in the bloodstream. That is the mechanism of LDL lowering of statins. So not only does it increase the LDL receptor, it becomes indiscriminate, and it also picks up triglyceride-rich lipoproteins. So the liver becomes fatty, the pancreas becomes fatty, which can disrupt insulin production. So we talked about diabetes. The second aspect of this is that as the body is making cholesterol, at about the 20th step, the pathway diverges and makes CoQ10. So let me take you back. There are many physicians in here. Let me take you back to the electron transport chain. And the electron transport chain is linked to the citric acid cycle. And as you convert acetoacetate to water and oxygen, water and carbon dioxide, you generate ATP molecules through the electron transport chain. And a key mediator, a key cofactor of electron transport chain is CoQ10. So CoQ10 is made from the cholesterol synthetic pathway. And when you remove CoQ10 from your body, your muscles are not able to function well. So you feel tired, you feel fatigued. And that's just dismissed by physicians because they don't have much time to talk to their patients. They say, oh, you're just getting old, or you're basically lazy. Now, let me stick to CoQ10 a little bit longer. Now, we're going to move to the brain. So as you know, we have a very robust blood-brain barrier. The blood-brain barrier prevents any cholesterol from crossing from the blood into the brain. And so the brain has to make the entirety of its own cholesterol from scratch. And brain is 2% of our body size. 25% of the brain, 25% of the body's cholesterol is in the brain. And one brain cell talks to another brain cell through cholesterol connections. In other words, neurotransmitters sit on a part of the membrane of the brain that's very cholesterol rich. Now, the brain is also energy hog because it uses a lot of energy. And in order to burn that energy into ATP, it needs CoQ10. CoQ10 is a cholesterol byproduct, and CoQ10 is not going to cross the blood-brain barrier. Whereas most of the statins, especially the lipophilic statins like simvastatin and atorvastatin, they cross the blood-brain barrier. So you're going to have cognitive effects. People are going to become a little slower in processing their memory and information. Like, for example, I came across a cardiologist, and he tells me that since he went on high-dose Lipitor, it takes him a little longer to process an EKG than it used to do before. I have a neurologist friend who is on a statin after a stent, and he says that when he sees an MRI scan, it takes him a little longer to process this information. So all of these side effects of statins should be known to the patient. Your bias should be known to the patient. You should tell them what the stance of the American Heart Association is, and let the patient decide for himself. I'm not sure there is a right answer. So if you ask me whether I prescribe a statin to a person who's metabolically unhealthy, my answer is that I go through the informed consent. I spend time with the patient and I tell them, this is the degree of benefit you're going to get. This is the conflict of interest and how the data was obtained. And these are the potential side effects. So I hope that answers your question, because I don't think anybody can give an answer that says that I know this for sure.
So that's great.
Thank you very much, sir.
So let's go to the next question. Spurti there. Spurti had some burning questions on eye and the metabolic patients that she's seeing. If you're around, you can unmute yourself and start asking the question. And Tracy Kimball is also online. If you want to go ahead, and Bobby Glenn is online. If you want to go ahead, if either three of one wants to go ahead. Bobby is raising her hand. You can unmute yourself and ask questions.
Yeah, so I have a list of them. I've been writing them down. Dr. Ali, I think there's a lot of things that we're missing. Let me introduce myself first. I'm a registered nurse. I have lived a well-formulated ketogenic diet for 28 years, and it massively changed my health and my metabolic health. I did research with Steve Finney and Sarah Hallberg on well-formulated ketogenic diets for about 10 years. And I've now own a business where I teach patients and I partner with primary care physicians. So I don't work.
What did you do before that?
I worked with Ravi. We started a health suite in his practice, and
it was 2015 when I was changing my journey from
yes,
being a doctor, and then that's when I had her, and she's in Lima still. Go ahead with your question. Maybe.
Well, I actually want to give Ravi a lot of appreciation, because one thing that I found as a nurse very unique to his approach to things is he overheard a conversation where I was talking about this, because I've lived it a long time, and he was very intellectually curious. And I really, really admired that when he started asking me questions, and I think it helped open his eyes to a lot of other research that was out there. But I do feel like there were some for people who are familiar with ketogenic diets and their effect on chronic diseases, some things that weren't really addressed. And I've made a list of them. But the first one I want to ask you about, Dr. Ali, because I think this goes back to your statement about the firefighters and the cholesterol, is what is your belief or impression? Because I have a position on this, but I'm really curious about if you agree, on the anti-inflammatory effect of a well-formulated ketogenic diet and that's relationship to heart disease.
Oh, no question that ketogenic diet is less inflammatory. There have been a lot of elegant studies that show significant reduction in many of the inflammation markers like CRP, insulin, erythrocyte sedimentation rate, many other markers that are not coming immediately to mind. So I agree with you that ketogenic diets have less inflammation, but there is a heterogeneous ketogenic diet, which means you can start at a vegan, sort of vegetarian ketogenic diet and go all the way to the Lion's diet. So the vegan, vegetarian ketogenic diet is very difficult to follow. there are some people on this forum, maybe if Ravi Krishnamurthy is there, he's one of the pioneers in how to design a diet that is ketogenic for vegetarian. And then you end up with the Lion's diet. And based on my clinical experience, based on talking to many, many people, I think by far the least inflammatory diet is the very restrictive Lion's diet. And the way you would describe the Lion's diet is that you eat nothing but meat and salt. And I have seen dramatic regression in many neurologic disorders, in urate nephropathy, in gout, in mental illness,
Yes.
and skin rashes, joint issues. Psoriasis has disappeared in people. So you fall on a spectrum. I think people fall on a spectrum of how much inflammation they get from plants versus also as you get more and more ketogenic in terms of dairy, in terms of non-ruminant meat. And my bias at this time, although I think science has not caught up with it, is that I hold the position that the Lion's diet is the least inflammatory of all the diets. And I'm interested in hearing your comments also.
Well, I really have to say and acknowledge it takes a lot of courage in an environment of medical professionals to actually even say that, because you're putting yourself in a position to be criticized, which I will not do. I promise you that. I respect that a lot. Since I have a business where I teach this, I have patients who are doing their own Dr. Google research and Dr. YouTube research on this, and they ask me about these things all the time. And my position, but I'm really curious to find the real medical, I'm trying to take an intelligent, cautious approach to this, is that maybe for the short term, because people do see such drastic improvements in all forms of their blood work. Plus, let's just mention the quality of their life. They think better, they sleep better, problems go away. Problems that they, like I had a patient whose migraines went away and she was dealing with 2 or 3 migraines a week. I had a patient who was doing this to lose weight, and her arthritis in her feet, which was so painful, it was really upsetting just living a normal life. And she's like, I'm going to do keto now for the rest of my life just because the pain is so improved, which she didn't expect. But I could go on with stories over the last 10, 15 years of patients who had these radical improvements and things that didn't even seem related. My concern is long-term on the carnivore or lion diet is their need for micronutrients. And that's where I tell patients, since there's no, I'm an N of 1 and I do eat some vegetables, but they're all low starch vegetables and they're in very controlled amounts. But I wonder, unless a patient is really willing to eat toe to tail of the animal, most people aren't going to eat liver, heart, brain, tongue, things like that. Do you feel that's a sustainable way to live, a sustainable diet, or is that a great way to maybe turn the metabolism around while you gradually work in the non-starchy vegetables and therefore, long-term make it a sustainable lifestyle so they can maintain those benefits that they've gained? What do you think about that?
So here I have to give you what I think and not what I know for sure. Right?
Same
Because
here. Yes.
my knowledge is not complete. So it depends on who you ask. If you ask Sean Baker is a very healthy person, and he eats nothing but meat, salt, and water. And he says, and the meat that he eats is muscle meat. He's not eating nose to tail. And he says that has worked for him, it's enough for him. But I'm sure that there is definitely some value in eating nose to tail. You're going to get almost everything, maybe with the exception of perhaps vitamin C. But if you look at the work of Amber O'Hearn, she talks about vitamin C being present in animal food and that the requirement for vitamin C goes down when you are on a pure carnivore diet.
Interesting.
In terms of micronutrients, I'm sure that the animal food has the highest content of all the micronutrients that you need, including magnesium and zinc, in terms of omega-3 fats, not ALA, but actual DHA and EPA. So I'm not sure. I mean, I won't say that I'm an expert in telling you whether I know the answer that you don't require any more micronutrients. I think perhaps there is a room for that. But I would be willing to say that it's a pretty safe diet for most people.
Thank you. I appreciate that perspective.
So if Tracy is ready, she can go ahead and ask her question.
Yes. Hello, Dr. Nadir. This is Dr. Kimball. I'm calling from Colorado. And Bobby, wonderful to have you join and share your lived experience of this.
Please introduce yourself too.
And I'm a wound care vascular surgeon and have been practicing mostly elder care, vascular and wound medicine since 2012, and operate a wound care clinic here in Colorado and Denver Metro. And my question is we deal with a lot of senescence and vascular dementia in our patients. And of course, they are being educated about the benefits of low cholesterol diets and management of their LDLs, although we're seeing more and more of them coming off of their statins later in life. And I would say the average age group is anywhere from 65 and older, let's just say that. In Colorado, people are very active, but in my patient population, the senescence is really high. And so I liked the analogy of the LDL firefighters. And so can you speak to that? Should we be treating them differently in terms of their diets to help reverse the vascular disease and inflammatory disease? Is it too late? Because they're dying from sepsis and chronic skin failure. And of course, all the complications of infectious disease and immunosuppression. And so any insights you can provide around that, metabolic syndrome, et cetera, would be grateful.
And thank you for that wonderful question. I would say that as people, I see a lot of octogenarians and older people who have reduced mobility, like you're talking about, severe peripheral vascular disease, having wounds, having significant cognitive issues. And many of these patients continue to be on statins. And there comes a point at which the disease is so far progressed that the degree of dementia and the significant organic changes in the brain are so advanced that at that point, it becomes an irreversible condition. Stopping the statins does not make a difference. It's very hard for you to regain metabolic health in these people because they have lost a significant amount of muscle mass. Their mobility is reduced. So at that point, if you're talking about that specific group of patients, you do what you can with the recognition that you're not going to make much progress. So I think that this intervention should start much earlier. It should start in the 50s and 60s, in which people should be taught how to maintain muscle mass, because muscle mass is an important aspect of quality of life. Muscle mass is an important aspect of reducing insulin resistance. Muscle mass is a sump for you to take in the carbs that people have eaten, and you're going to eat carbs in this world, even if you are perfect or try to be perfect with a well-formulated ketogenic diet. And then consider stopping some of these drugs that become a lot more in terms of their side effects on cognitive issues. So that conversation should happen not that late. That conversation, we need to train the public, the population, and not the physicians themselves, because I think that this change of viewing metabolic health as the most important aspect of your life, your muscle health as the most important aspect of your life, is going to come from grounds up. It's not going to come from top down. It's not going to come from American Heart Association or any other physician-led organization, because their incentive and the people who are driving them are pharmaceutical and device industries and big food. And the big food has shifted predominantly towards processed food, which is very high in carbs, in seed oils. So this is a grounds up movement. And I don't know if that completely answers your question, but I'm sure that there are points in which there is diminishing return to changing somebody's health when they are that far gone. I hope you see a group of patients that are more gratifying to you because the efforts you put in to change their metabolic health creates a significant degree of improvement in them.
Yeah. I mean, I do get where Tracy is coming from, because I do most of like the half of what she does. I mean, senescence and dementia is huge, and what I see in my patients is significant amount of sarcopenia, and obviously with all the oxidized LDL and all the things going on, we are losing mitochondria, which are mostly resident in the muscle, and losing mitochondria and then not able to metabolize correctly. And also we have to bring together, what do you think, Dr. Ali, is at the end of the day, everything goes on in mitochondria, your electron transport chain and all. How about the reactive oxygen species formation in the mitochondria when cytochrome pathway 1 or 2? There's a difference between how the metabolic aspect, where if you're a carb burner, you're going to 1, and if you're a fat burner, you're going to 2, producing less amount of ketone. Do you think that matters?
That's a very good point that you made, Ravi, that burning fat generates less free oxygen radicals, and it gives you a lower inflammatory risk. You're not burning something that's unclean. The ketones and the fat is a much cleaner burning fuel, so you have lower reactive oxygen species. But whether that translates actually into a clinically meaningful outcome-based endpoint, I'm not sure I know that or anybody knows that. But for sure, I think it's a reasonable thing to consider and practice.
I think what is happening there in my idea of thinking is, when the person's insulin level is low, that's when the fat burns. Insulin is a fat storing hormone. If the insulin is down, then the fat is mobilized. That's the only way that fat can be mobilized. And the only way the fat is burnt is when it becomes converted into the ketones. That's the way anybody is going to really lose fat mass disease. So in particularly when it comes to wound care, I see that a lot, where if I'm able to provide that anti-inflammatory approach, the wounds seem to be getting better. But overall, when the people have insulin resistance and metabolic syndrome, which is the root cause where things have to be addressed, the idea of taking the waist circumference is a must in healthcare, which is not happening. Simple waist circumference is not being done, and waist to height ratio will be a no-cost approach that every physician has to take. Tracy, thank you very much. I mean, there's a lot more coming in wound care world. Please, you guys hang in there. And also the next question, Spurti, go ahead. If you're around, please ask Dr. Nadir Ali a question, because I see a few texts that Spurti put in, Dr. Ali. She's an eye doctor in India, and she asks very good questions. I mean, like from a perspective of a metabolic focused physician, what is mostly happening in healthcare is diabetic arteriopathy is great in the peripheral vascular disease. Neuropathy is great, happens. And nephropathy, of course, none of them is great. Of course, they're worse, but nephropathy, but retinopathy. So all this, I think we have to understand, in my thought process from a metabolic understanding is where the glucose in the polyol pathway gets converted into sorbitol, and then that goes and gets deposited on these nerves and these cells which don't have the protection mechanism, and they are taking the brunt first. So, I mean, if you're on, please ask your question. What was that she was talking about? What is discussion on NCPB? Could you clarify its significance? I'm not sure what NCPB is. For the plaque reoccurrence or plaque volume, I guess, Nadir. What do you think about plaque occurrence and plaque resolution? Is there a question? Is there something you can address? How do you see with this dietary approach? I saw in the movie a few people having plaque regression. So how do you think it is happening? And like if calcium deposits in the breast are the same as the calcium deposits in the heart, can calcium deposits regress?
That's a very good question, Ravi. So you're asking about non-calcified plaque volume, and you're asking about calcified plaque volume, that is the abbreviations that you used. And then you're talking about plaque regression. So it's a little too simplistic. When Dave said in the movie that there were 6 people in the original analysis that had plaque regression. And then when they sent it to an AI company called HeartFlow, there were about 18 patients with plaque regression. So there's a YouTube video of mine that's going to come out, which is going to talk about the limitations of coronary CT angiography and how to utilize that information in order to look at changes in non-calcified plaque volume and calcium score and calcified plaque volume, especially with relation to regression trials. So to just give you a brief overview of that, there are 3 limitations of coronary CT angiogram that we don't understand. Number 1 is spatial resolution. Spatial resolution is 0.5 millimeters. So that means that when you look at a slice of a coronary CT angiogram, a coronary artery is about 2.5 millimeters thick. So if your spatial resolution is 0.5 millimeter, that means you have about a 1/5 error. Whoa. The second thing is slice thickness. The slice thickness of a coronary CT angiogram is about 0.6 millimeters. So anything in between slices, you're going to miss. The third and most important aspect of coronary CT angiogram is something called temporal resolution. How fast is it for the coronary CT to be able to take a picture? And it takes about 140 milliseconds for a single source CT scanner to take a picture. And in that 140 milliseconds, the heart can move as much as about 1.5 to 2 millimeters. So that creates an error. So when you look at serial studies, in other words, study done at time 0 and study done at 1 year or 4 years, the patient is scanned at 2 different times. And just based on the physical limitations and some of the biologic changes that I've not gone into that don't relate to plaque progression. So in other words, the person is unchanged from year 1 to year 5. Or let's make it a little simpler. You scan the patient the first day, and then you scan him 1 week later, in which there is very little likelihood for biologic progression of plaque. Mm-hmm. So there is something called minimal detectable change that the coronary CT angiogram can detect for you to tell whether it's actually a real change or this change is within the limits of errors of the technique. So for non-calcified plaque, the change in plaque has to be about 400 cubic millimeters. So that's a huge change. And none of the participants in the keto CTA study had that degree of plaque progression or regression. Patients had plaque regression. What you're saying is that 18 patients had information in which the plaque was within the margin of error. So you cannot say it on an individual basis. That point needs to be clarified. I don't fault Dave Feldman for not being able to do that, because it takes time to explain all the stuff that I have told you.
Yeah.
And I only gave you half the story.
So I know, please raise your hand if you have any questions, because I want to really go through some rapid questions that I was doing for the movie to try to come up with how I can utilize the time correctly. I will go through them, Dr. Ali. Please answer them, because these are common questions that some people might have regarding the movie. So the keto CTA study was plaque begets plaque paper that was published, and the paper recently had been redacted. Does this invalidate the entire argument?
No, not at all. Let me explain, because I was pretty privy and I worked closely with Dave Feldman with regards to this information about the quantitative plaque analysis. Quantitative plaque analysis means that on coronary CT angiogram, you're getting total plaque volume, non-calcified plaque volume, and you're getting calcified plaque volume and calcium score. And how was that gathered? So the information was gathered in a coronary CT angiogram in a DICOM image. It was sent to an AI company. I'm not going to tell the name of the AI company. And the AI company then analyzed those two scans, and the scan results that this particular AI company analyzed and that was used for the paper were completely different than some other AI companies like HeartFlow or QAngio, to mention a few other companies that analyze the quantitative plaque analysis. So what Dave did was that he said, there are several patients in this study who want to independently analyze their plaque on their own. So many of these patients sent me their CDs, and I took their CDs and I sent it to the same AI company that was used to get the information for the study paper that was published. And lo and behold, the 10 patients that sent me the studies, their QCA analysis, their quantitative plaque analysis, did not match the original analysis. So in other words, there was a difference in either half the patients having more plaque and half the patients having less plaque than the original analysis showed. So the question was, why was there such a significant difference? Because if you're sending it to the AI company, you would expect exactly the same result, but the results were not the same. And that's when we realized that there is all these errors that are built into the AI company software. Like, for example, there's an algorithmic error. In other words, the AI software company analyzes the coronary arteries, and it depends on where it stops. There is also a center line method in which it traces the center line and says, this is how I'm going to analyze it. And that has errors. So based on those factors, they said that this data is not robust. We should retract this data and we should present it with an AI software company that is much more rigorous in their analysis and talks about their minimal detectable change at an individual and group level. So that's happening right now, and that's why the study was retracted from that standpoint.
Oh.
But the other aspects of the study remain robust, which means that LDL had no association with plaque progression, number one. Number two, that was pretty robust, is that the semi-quantitative analysis that Dr. Budoff presented did not show any significant plaque progression in this group of people that the mainstream medicine reacts as very high risk for progression of coronary artery disease. So I hope that answers that question.
Yeah. Yeah, that's question. I will go to my prepared questions later. Spurti, if you have a question, please.
Hi, Dr.
Yeah, go ahead.
Hi, Dr. Thank you. First, I'd like to ask just a clarification because Dr. Riker in the LDL group had posted that there was some increase in the non-calcific plaque volume by around 48%. I wasn't sure what exactly it meant. Can you please clarify on that? Did it really show that increase in or was it just
So Spurti, you're talking about the keto CTA study here, that there was an increase in non-calcified plaque volume?
Yeah, I read it in one of the discussions. So what
Correct.
does it mean?
You're right in saying that the clearly analysis did show that there was an increase in non-calcified plaque volume from time 0 to time 1 year. But that increase in calcified plaque volume was well within the group minimal detectable change based on several previous studies. And also, it has become invalidated now because the study is doubting whether the company that did the AI analysis had some robust checks and balances with regards to how they analyzed the data. Were they completely blinded or were they not blinded? Did they have some bias in how they analyzed the data? Because many other companies that do AI analysis did not come up with the same degree of change in non-calcified plaque volume. So I don't know if that answers your question.
Okay, thank you. So I'd now like to shift to ophthalmology, especially retina, because you were talking about CT angiography and the limitation of its resolution. What we see in the retina is a microscopic and micron level resolution we have, and we have specific imaging modalities in which we can see in real time how it is like a reflection of the metabolic health. But the problem with ophthalmologists, we specialize after MBBS and then medicine and cardiology, that is a different stream. So that departmental, we don't have that much interaction. So my experience I would like to share is when I was doing post-graduation back in 2014, our institute had published a paper back in 2004 on the effect of atorvastatin on the reduction of hard exudates in the retina. And it was it had around 30 patients, and it's a very highly cited research. So it was our practice to include a lipid profile in the diabetic macular edema patients. And if those patients were not on statins, we would recommend starting a statin because that has shown that the hard exudates resolve. But over the years, what we have observed is that right now, the kind of diabetic macular edemas, which are recalcitrant, which are not responding to treatments and who have a lot of hard exudates, which are basically lipid deposits, those patients are already on statins. Their LDL remains normal. So what I've started noticing is that these retina, they correlate with the metabolic syndrome phenotype. The patients who are further in the extreme metabolic syndrome, who have very high central obesity and a very low muscle mass, and whose triglycerides and triglyceride to HDL ratio is very high, those are the ones who have worse retina. And there is very less research on this correlation between the hard exudates and the TG by HDL ratio. So I'm working on that right now. But I feel there should be more involvement of a retina specialist for a feedback on how a treatment is, how a patient is responding, because you get a real-time assessment of how the microvasculature is responding to any treatment. So I'm yet to see a patient who's on a keto is improved metabolically. I am yet to see a patient who has improved, because in India it's very hard to see a patient who's on a keto diet. So I'm still haven't seen a diabetic patient who has entered remission. and I haven't seen a patient who has improved.
Well, you gave some very good insight, Dr. Spurti, and I'm glad for that. Like you said, some of the things, if I can re-speak or rephrase, is that you've seen a lot of retinal disease in people with high triglycerides to HDL ratio. That's the very definition of metabolic syndrome. That's the very definition of an unhealthy, what I would call as an atherogenic and insulin-resistant lipid profile. I'm sorry that you have not seen people who have changed their metabolic health and seen an improvement in their retinal health. But one of the person that comes immediately to mind that was there in the movie is Dr. Richard Bernstein. Dr. Bernstein had advanced retinopathy in his 40s and 50s. This is the man who was a type 1 diabetic who changed his life, who talked about the law of small numbers, who talked about how low-carb diet helps diabetic people. And he lived to the ripe old age of 94, I think. He died last year in 2025. So this is a gentleman who had diabetic retinopathy, who managed to change it and improve it, and lived about 45 years after that. So I hope that you come across people or you find a nurse practitioner or a nurse to whom you can refer your patients to, because there needs an education on how to implement a low-carb diet. Like, for example, if you take a person who has high triglycerides, low HDL, and you tell them to start a standard low-carb, high-fat diet, they're going to get worse, in my opinion.
Yeah.
These people need other interventions first.
Okay. So, Spurti, I mean, like the reason why I was amazed, because eye is the window to the metabolic health, and that's where the micro changes can be monitored or tracked and initiated. So please don't give up on that thought. I want to empower you in whatever way we can to make that impactful difference that you want to see for your patients. Number two, around you, there is that Dr. Sethi is around. He's doing it in his clinic. And what we are working on with him also is to put in some solutions that involve food logging, glucose monitoring, metabolic monitoring, and maybe please reach out to Dr. Sethi, and then we'll figure out a way in which maybe your eye pictures can get into the platform that Dr. Sethi is going to have. And see, the detail, the devil is in the detail in metabolic health. And the beauty is, without knowing, i.e., without communication, personalization, realization, implementation, and reevaluation, these are the 5 things of change that the end person has to go through. So it took me 20 years of being a doctor to really flip into this side, but I'm not able to give up on what I do in medicine, but I'm seeing this change happen in every day in my patients. So metabolic ill health is causing major problems in healthcare. And if you don't take ownership of that and try to improve upon, I mean, that is the reason why major burnout in healthcare is happening. And that's what I hope. That's one of the reasons why I have sponsored this thing through my nonprofit organization. And my nonprofit organization that we have is focused on healthcare in India and obviously across the world. So we have a global health project, and we're going to help you. That's the question. I mean, I don't know how, but we'll make it happen. So that's one of the sponsors of this. That's why we did this for this movie today. So there was another question. Yeah, go ahead.
The problem is a lack of real-world data from India.
Yeah,
which because of which we rely on Western data, and the guidelines are all based on the data which has been generated. So I am seeing a lot of patients who are, their diet is completely deficient in terms of protein, carbohydrate predominant diet, and they are trying to compensate that with sulfonide. The glimepiride is used rampantly. Glimepiride, gliclazide is the after metformin, that is what they're on. And I feel, it's not my feeling, it is a common sense now that maybe that is the reason, the insulin levels and the high insulin resistance, that is what is leading to the worsening of the retinopathy. But that is not documented anywhere. So in the guidelines for retinopathy, if I went through the whole textbook chapter and I went through the guidelines, there is no mention of insulin resistance or how you should treat the diabetes. All they're focused on is the glycemic numbers. You have to reduce HbA1c, and if glycemic control is how you will prevent retinopathy. But that is like a tip of the iceberg. You have to really focus on the metabolism, and we will work on it. I'm in touch with Dr. Ashish Sethi. That's how I came in touch with you. So we are working. I am referring my patients. It will take some time, but we'll come up with some evidence.
So like you said about data, see, remember, data is the new gold. And the problem is connecting the dots in healthcare. So that's what I see. You see that in the diabetic retinopathy, but I see that in the diabetic foot. So whenever I try to say, we started an organization called Indian Podiatry Association in 2008 and 9, we have trained around 5,000 doctors across the country. India is not an easy aspect to deliver care because costs are so, is minimal costs or at least no cost. Everybody wants it free. But the issue is simple. How we can bring the Indian data for India. Most of the work that is being done is coding American data. Now, it's a population health data that is a problem in every aspect of medicine because real medicine happens at the power of one. And that is where then the hijack of medicine is happening, where entities that are trying to provide us tools. So if tomorrow there's a medication that comes, they have to market it. So we have to understand where industry is coming from. Industry is going to give you the food that you need. Industry is going to behave the way you want to because it needs money to survive and it's going to do it. So the question is, we healthcare professionals have to own this because, see, patients pay us. They don't pay them. And we have taken an oath to serve. And then that means you're blessed by good Lord to serve. So let's take that ownership. Let's try to connect the dots, communicate, not avoid the silos of healthcare healing by communicating with as a colleagues. So that's why we have a company that I'm trying to come up with. See, again, money comes in this whole thing, which I don't even want to bring in. So the question is, delivery of care needs high-tech solution and data. India, let me tell you, is going to be the magical moment for healthcare in the future. Either Indian doctors or Indian professionals, Indian patients take ownership of it. By 2047, it will be a great nation. If not, it'll be in real trouble because of the genetic makeup, because of the fat mass disease, because of thin on the outside, fat on the inside aspect. So I can keep going. I don't want to, but let me tell you, things will happen because you don't give up. This journey, this train is not stopping. Let me tell you, this train will not stop till the last day I take a breath. So I'm not making a statement. This is the truth. So I just get riled up very easily. I'm so sorry. So Tracy had a question. Are we being advised to work up and describe the thyroid cortisol axis before initiating ketogenic diet? Tell me, Dr. Ali, do we have to address the thyroid cortisol? I thought insulin was a master hormone and you have to help its stimulation better than going the downstream aspect of it. What do you think?
Absolutely, that cortisol, the pituitary adrenal cortisol axis is very important with regards to health because it's an allostatic hormone. It goes up at the time of stress, and chronic elevations of cortisol will cause insulin resistance, will cause muscle breakdown, muscle loss because you promote gluconeogenesis. So definitely through lifestyle, you not only need to address high or elevated cortisol levels, but in order to address that, you do the same thing that you do for insulin resistance. You talk about how to reduce insulin, you talk about physical exercise, you talk about fasting, you talk about sleep. All of these are important aspects on improving and helping both aspects. Now, I just wanted to point out that Ashish has had his hand up for some time, so I don't know if he wants to say something.
Go ahead,
I
Ashish.
hello, Dr. Nadir, it's Dr. Ashish here. I had a query regarding you mentioned about the coronary angiography having its false positives and false negatives. So what do you see? Do you think that this coronary angiography remains a perfect step in the study of this keto diet? Because postmortem studies do show that uh, at the age of 55, the average of the study was two-thirds or 70% of the people will have plaques. So do you feel this CT angiography was the perfect or the only available option available for doing this study? That was the question number one. And question number two, I want you to dissect the real recent South Korean study also on LDL.
Okay, so let me address the first question first, Ashish. Yes, there is no imaging modality that is going to be perfect, but CT coronary angiogram has gone through a lot of evolution. Now, first we had single source CT scanners, and I talked about temporal resolution of about 140 milliseconds. The dual source CT scanners are going to reduce it to about 70 milliseconds. So the temporal resolution is going to improve quite dramatically. The slice thickness may go down. And now there is another technology which is called photon counting CT scanners, which may improve the spatial resolution even further. But even with the given technology that we have, when you come to analyzing group, like in other words, group change in plaque volume, it's a very powerful tool to see what you're looking at if it is done properly with good controls. So I'm very optimistic that this is a good technology to use, and it's going to help us understand nutritional changes much better with regards to plaque volume. Now, with regards to the Korean LDL study, it doesn't come immediately to mind. So you might as well tell us what that study was and what it showed.
That's a recently published NEJM study on the massive reduction in LDL, right from less than 70 to attempt to less than 50. And they have shown not, I would say, a 2% or a 3% decrease in absolute risk of coronary events, not of any decrease in significant decrease in mortality. So I think Ravi knows about the study, and Ravi can take this further from here.
I think, Ravi, you're muted.
This was the NEJM study that just came out, Nadir, that was talking about different aspects where they're trying to use other aspects of reduction. Basically, they were intensively reducing the LDL, and the question is, I would say that glycemic surge is impacting insulin. That impacts hepatic flux, what happens, and that impacts ApoB, that impacts metabolic events, and that leads to vascular disease and chronic diseases. And that study, I think, was showing lowering ApoB
We
to
can
LDL.
talk a little bit about different aspects of it, but let's put it on hold. We can come back to it. Let's see if anybody else has anything else.
It's a complicated one. Yes, that's a good call. But I think, yeah, Bobby, go ahead.
I was wondering if Dr. Ali, again, another thing that I felt was not addressed in the movie is specifically in regards to LDL on a well-formulated ketogenic diet, is they didn't mention anything about the fractionated LDL and that all LDL is not the same. If you refer back to the research of Dr. Ron Krauss, where you can have small, dense, oxidized, injurious LDL, and then you can also have types of LDL that are buoyant and fluffy and are primarily there to deliver, fat around the body to be used and removed from storage to be used as energy. How do you see that in a ketogenic or carnivore diet? What I've read and seen in some of our research is that it when the LDL goes up, it almost always becomes, I can't speak 100%, so I'm not saying we saw negative results, but I can't speak to 100%. We saw it switch to the buoyant fluffy, which is not injurious to the internal epithelial tissue. Am I understanding that correctly, or do you have any comments or observations on that for our group today?
That's a very good observation, Bobby. And I'll tell you my own bias, and I'll give you information from my practice. So as people go on a more restricted carbohydrate diet, as they become more and more ketogenic, as they lose weight, just like Dave Perlman pointed out, the leanest people have the highest increase in their LDL. So in other words, LDL cholesterol is the total cholesterol, but how many particles make up that total cholesterol? So the LDL particle number goes up, and just like you said, as they become more and more metabolically healthy, the overall change in the particle size is larger and fluffy. So that aspect I have seen and I agree with. But what is not well stated is that not only do your large particles go up, but you referred to the small dense particles that they go down. And that's not correct, because as the total number of particles goes up, so does the small dense LDL particles go up. In addition to the overall pattern changing towards large and fluffy. Now, the question that comes about, and this is where my bias comes in, is that do you view small dense LDL particles as atherogenic? Or do you view small dense LDL particles as something that got involved in the process of injury in order to dampen inflammation, in order to provide repair? So in other words, I'm going back to the same concept of, are they firefighters or are they arsonists? And my basic premise is that not only is small dense LDL a firefighter, but so is the oxidized LDL, which is considered to be the most dangerous form of LDL that's already been altered by free radical injury. So it depends on your perspective. And my perspective is that LDL per se is not inciting a coronary plaque or a vascular plaque. It is in there because an injury has happened. It's a very strong anti-inflammatory molecule. It's got a phospholipid layer that can get oxidized. It has got CoQ10. It's got vitamin E in it. It's got a lot of material that is trying to help repair that injury. And in order to come up with a simplistic explanation that LDL itself is causal in vascular disease, in my opinion, is not a settled matter, needs a lot more investigation and science.
Good. Thank you, Bobby. And like I said, again, it comes to the personalized approach. We have a question here from Dr. Durga Prasad in Hyderabad, from where you are, Dr. Ali. He is asking, is there a racial ethnic difference between how patients on low carb respond, who are more prone to become a lean mass hyperresponder, or does it depend upon other things? What are the difference between depending upon the body mass? What is the difference, and what is the best way to monitor their cardiac health long term?
Wow, that's a pretty broad question. I would say that if you have an Indian type of phenotype, I come from India, I come from Hyderabad, like Dr. Durga Prasad. So Indian phenotype, at least when I was growing up, and now I know it's changing quite significantly, is one of low muscle mass. The Indian phenotype becomes a diabetic at much lower weight than the Caucasians do. So this group is very prone to metabolic ill health. And I'm not sure exactly what the reasons for that is. It might be a combination of genetics. It might be a combination of a very high reliance on seed oils or vegetable oils that by design are very inflammatory. It could be related to intestinal permeability, or what is called SIBO, small intestinal bacterial overgrowth, that can cause some degree of immunologic and inflammatory damage to the pancreas. So I'm talking a little high level out here. So this phenotype, probably just a dietary modification alone is not sufficient for them. This phenotype has to come up with ways to increase muscle mass through proper exercise. The change in diet should not only be a reduction in simple carb and sugar intake, but also should be a dramatic elimination of seed oils, which is very pervasive and all around us in every part of the world.
Mhm.
And then they have to start out with an evaluation of their metabolic panel. How unhealthy a lipid profile is it? Do they have high triglycerides, low HDL? Do they have already markers of fatty liver disease or hepatic steatosis? So I would encourage Dr. Durga Prasad to individualize his patients, because in some of them, the initial focus may be on intermittent fasting, high protein diet, physical exercise, and not on a standard low carb diet. That cannot be emphasized enough.
So I know we have been going on and there will be more, but I will go through some rapid questions naturally. Before I go to the rapid questions, I just want to address one thing that Durga Prasad brought. So our genes are genes. We are born with them, say, basically you could have mixed genetics from European and whatever you have, or it could be Caucasians and African American genes, whatever. Now you're worried, you're scratching head. What am I to do? So I think genes and genetic expression would depend upon the information. The food is the information apart from the energy. Now, the dietary approaches that anybody takes, vegetarian, non-vegetarian, whatever, tracking it is key. So like you see in the movie, Dave was tracking everything that he ate. Now it's hard, okay? We are monkey minds. We are carrying a monkey mind in between these ears, and we are exposed to the nose, smell, mouth, and all the things that we are exposed to. Of course, this is how I talk to my patients too, by the way. And then the question is simple. And how I tell them is, hey, take a meter. This is a glucose and ketone meter. And sometimes, it is not available in India. But see, when there is a volume and a need, it will be available anywhere. Now, even Dr. Ashish Sethi kind of got one in his by himself. So the idea is of all the diets that are there. So the problem is we are married to the diets. No, we should be married to our own body. We are living in this body. We live, suffer, grow, and learn and die. And if we don't go through this process of learning, we will come back again to learn. So the question is simple. Please understand the analogy of these triangles and understand using the dietary approach, whatever you prefer, but track it and use technology, tools, techniques, and process. Learn so that, number one, forget about the patient. Let's fix ourselves as a medical professional so that we can scale it to the next level. And the impact is going to be huge and it's going to be awesome. So after that rant, I'm sorry, let me go with the real next questions, rapid questions, Dr. Ali. So
can I ask one thing, Doctor?
Yeah.
It's very related to India. What I found in my group of people, because I follow them, get plasma insulin levels very regularly. Many of them have already gone into pancreatic failures, or if we call them as pancreatic failures, the insulin levels being 5 or 6 or 7, already requiring 2 or 3 antidiabetics, and they are 50, 55. They may or may not be obese. I don't feel they are moody. So, what do you do about these group of patients? Are they irreversible? They're born beyond a point. What do you think, Dr. Ali, please?
Ashish, that's such an insightful question that you have, because let me rephrase it, what you have said. And I find this in the practice out here in the United States, also among the South Asian population, which is that they have advanced pancreatic failure. Advanced pancreatic failure means that if you take a group of Caucasian people who are type 2 diabetics, their insulin levels are high, they're not low. But what we find in people of the Indian phenotype is that they have low insulin levels. So at that point, you need to check their pancreatic reserve. So Ashish, are you an internist?
The gastroenterologist.
Gastroenterologist. Okay, so you are an internist because you went through internist to become a gastroenterologist. So in these people, I check their pancreatic reserve and I do what is called a modified Kraft protocol. And I don't know if you know what the Kraft protocol is, but Joseph Kraft, just like Dr. Richard Bernstein, did some very seminal work in this area. And I have a few YouTube videos addressing the pancreatic stress test that I do. And it is based on the work of two individuals. One of them is Dr. Joseph Kraft, and the second one is Dr. Roger Unger, who is a fellow Texan. Both of them have died. So what Dr. Unger did, in addition to what Dr. Kraft did, is that not only did he check sugar levels with regards to a glucose tolerance test. In other words, you give somebody 100 grams of glucose, and then you check sugars and insulin at 1, 2, 3, and 4 hours, or you can start at 30 minutes, 1, 2, and 4 hours. You can have a different protocol. But to that, I add C-peptide and glucagon. So as you know, there is a very strong interaction between the alpha cells in our pancreas versus the beta cells in our pancreas that are juxtaposed to each other. They're right next to each other. The beta cells are making insulin, the alpha cells are making glucagon. And the paracrine effect is that as the insulin goes up, the glucagon gets shut down. So if you do the combined pancreatic stress test and you find evidence of pancreatic failure, and let me tell you what pancreatic failure would look like. You give them a glucose load, the sugar levels go up, the insulin does not go up very much from a fasting level, and the glucagon, instead of getting suppressed, actually increases. As you know, glucagon is a hormone that tells the liver to release sugar into the bloodstream. It goes to the muscles and says, hey, now you promote gluconeogenesis.
So here is an omega-6 molecule. And the reason it's called polyunsaturated is because it has double.
I don't know where that came from.
Yeah.
But anyway, so I encourage you to look at my YouTube video that talks about insulin resistance and that talks about the pancreatic stress test, and evaluate pancreatic failure in these patients, Ashish.
Yeah.
And if you find that they have pancreatic failure, then your approach should be different. You're not going to tell them that your pancreas is going to improve. This is the group of patients in whom you need to shut down glucagon. And to shut down glucagon, you got to use either the DDP4 inhibitors, which are oral agents, or if appropriate, you need to use a GLP-1 agonist, along with small doses of exogenous insulin. So this is what Dr. Bernstein always promoted. So do not think about type 2 diabetes as a binary disease. It's a continuum. If you are in pancreatic failure, you need to treat them differently.
So Dr. Ali, thank you very much. Please, if you can find that link and post it in the chat, that would be great. As before the end of it, not and if you can, that's fine. But I will be asking you questions. But in the chat also, I posted two videos. Please watch that, where I have done the same thing without knowing Dr. Ali did it. So I have the links that I put in there. One, what I've done is also had the patient then take the glucose ketone meter at the same time and use when they're drawing the blood, I had the patient use the glucose and ketone meter. And what it showed me was the patient was already in nutritional ketosis, but I just, even before she was having hypoglycemic episodes. So I said, let me go and give you this test. And she decided to go and do it. And basically she was having sarcopenia and also having this problem. So I see a lot of patients with headache. Most patients with headache are being blamed as migraines and given all this migraine medication. So medication misuse. And the problem is you're treating the symptom, not the disease. And when I'm able to use a technique where I empowered the patient, then she did it. She was not having any problems, and she took this. And this whole thing, you will see the graph and you will see her experience video that I have there. So that said, it has been quite some time. There's going to be many more questions. And I think I have that group where I can put that group link also, so that we can have the discussion in the WhatsApp group, that we can continue, and maybe in 2 or 3 months we can join back and come up with that thing of what to do with that. But let me just quickly, in the context, because we're talking about the movie and now metabolism and ApoB. So from what this discussion is, the rapid questions I'm going to go through, Dr. Ali. Next question is, are you saying ApoB doesn't cause atherosclerosis?
That's a pretty difficult question to give a binary answer. I can tell you my bias. My bias is that there is not information for us to implicate it. And whenever I say that, I look at Bobby and I look at her expression and I see that she is affirmative in that. So I get pleased by that response. But I don't think that there is enough proof that ApoB in any setting, whether it's a lean mass hyperresponder, whether it's a person who's severely metabolically unhealthy, that there is a proven role of ApoB in causation. Definitely there's an association, but is causation proved? I'm not sure that we have done enough research and enough good research to answer that question.
Thank you. My comment would be causation is different than association. When you do population health, you don't get the cause, you get the association, and the association data is being used in population health data being pushed across mass medicine mindset, not a power of one approach n equal to one medicine that really happens in medicine. So next question. All this, is this just keto bias?
Definitely you have to be careful about your own biases, because sometimes you look at your bias and you only pick up information that supports your bias, or which is called confirmation bias. The capacity for self-examination, as Socrates said, is one of the most important aspects of your makeup. And you should be beholden to science and not to dogma. So if tomorrow things come out that says that we were all wrong, we should be willing to accept it.
That's great. That all comes down to self-awareness, self-realization, continual process of improvement through what we call this drama of life. Thank you very much. So next question. Guidelines clearly say LDL over ApoB is better. Why challenge that now?
Now, when you're talking about LDL and ApoB, it is like, if you're paraphrasing yourself.
Lower LDL to ApoB ratio is, clearly they say that's better. Why should we challenge that now?
Well, I think you're talking about the same thing, because LDL has the ApoB lipoprotein. And if you measure ApoB, there also is ApoB lipoprotein, but ApoB lipoprotein is also present in VLDL.
Yeah.
So you're adding triglycerides to it. And the reason now there is a focus on saying that I don't care about your LDL levels, I just want your ApoB levels to be low, in my mind is a marketing gimmick by the statin manufacturers, because it would be even wrong to focus only on LDL just like our ophthalmologist just explained, Dr. Spurti, that the patient population that she's seeing is high triglycerides, low HDL. So you will be treating high ApoB in a setting of people with hypertriglyceridemia while completely ignoring the high triglycerides.
Yeah.
And as you know, statins are going to worsen metabolic syndrome. There is a strong relationship of statins with both insulin resistance and diabetes.
Yeah. So, I mean, I would add, say, it's already, we are beyond guidelines right now. We're talking Lp(a), we are talking CAC, we are talking different risk modifiers. So this discussion is not anti-guidelines. It is precision medicine within the guideline framework. So guidelines are not gospel, guidelines are guideposts. So next question, should patients ignore LDL and stop statins?
No, I don't think they should do that, but I think that their physician, and I don't know who it was, but she had mentioned that that's a very definition of informed consent. But the physician should sit down with their patients and explain the 4-step informed consent with regards to statins.
Yeah.
And if at that point the patient wants to continue the statins or discontinue the statins, it should be empowered to them to make their own decision based on the information they got. So
Thank
I
you.
don't think that the physician has any right to tell the patient to stop the statin. They should talk about absolute and relative risk reduction and all the other 4 points that I talked about.
Yeah, not scare them. And you know, there had to be a consent, a mutual consent, understanding the risk benefit ratio and the side effect discussion of anything, and then bring it down to understanding if ApoB is causal or what else really matters, Dr. Ali. What else really matters?
Well, we talked about it as to what else really matters. We talked about insulin resistance being a cause. We talked about sugar coating of proteins that increase the risks of vascular disease. We talked about inflammation as a major factor. We talked about ectopic fat deposition as a major factor. So these are all factors that you need to address. And the very important paradox out here is that when you address each and every one of these factors, in other words, you're addressing insulin resistance, you're addressing glycation, you're addressing inflammation, all of these things are going to increase your LDL levels.
Good, good. So,
and another aspect would be that statins are going to make all of these things worse.
And cause diabetes.
Sure. Thank you, Bobby.
Yeah. So, I mean, I would think that what matters is mechanistically. I mean, my mind works mechanistically. I'm not as detailed as Dr. Ali because I don't understand it that deeply. But I think if this is the reason, ApoB, okay, if we accept that, then we have to understand how is it produced, how is it cleared, and what is the environment. So it's produced in the liver, and there is output. It's driven by insulin resistance and liver fat. So what are we doing for liver fat for the people? Are we preventing more liver fat accumulation or not? And then in the clearance aspect, it just comes down to I just recently came to know that ApoC that is on each ApoB is very important. I did not know that. I mean, like, this is like crazy. And LPL activity, lipoprotein lipase activity, and remnant cholesterol metabolism is key. And also, it just comes down to inflammation, endothelial health, and thrombosis risk, and all this. And next question is, isn't plaque imaging more important than lipids?
I think both are important. The plaque imaging gives you what has happened to you over the history of the several years previously. And your lipid imaging is more current. It's going to give you your current metabolic health. So you need both.
Yeah, I think ApoB can be taken as a risk signal, and we can do the imaging and work with metabolism. Disease happens because as the end cause of some major problem, and that's what we have to do. And what's your core disagreements with conventional thinking, Dr. Ali?
You want to get me into trouble.
I mean, there is, I
Sure.
mean,
I think,
basically, I would think it is incomplete. That's what I would think. It's, I mean, see, we humans come from our own understanding, and our thinking possibly because of your situation, exposure, and whatever, I think it's incomplete. This is not replacement of the current thinking, which just is an evolution of the current thinking. I think that needs a new clinical framework, new approach, and tell me what you think about that.
I think there is a huge paradigm shift here, Ravi, because the physicians are very prescriptive. They are driven by prescribing medicines. And what I want to change is for them to recognize as to how little an impact we have on chronic diseases, diabetes, the potential for malignancy, hypertension, obesity, insulin resistance, renal failure. You can name all of these.
Yeah. So, yeah.
Recognize the magnitude of benefit that you get from a significant change in lifestyle. And the lifestyle is not just uniform with regards to nutrition alone, but it is individualized nutrition. It's an exercise program that is guided by recovery. It is sleep. It is intermittent fasting. All of these are incredibly valuable tools that the mainstream medicine has just basically glossed over.
Yeah.
They don't even pay attention to those. And unless your focus moves back to that has to be a huge paradigm shift.
Yeah.
If that focus is not there, then if you look at chronic diseases, the degree of benefit to be gained by all these medical therapies is very marginal and small.
Yeah. Yeah. So, I mean, that said, conventional thinking, what my perspective is, yes, I'm going to call it incomplete, but also this model of care has to change because of insulin resistance, metabolic health, individual variability, and lipoprotein metabolism, which I really did not understand. And of course, endothelial damage. And the question is, how can we then take this to the next level? How can the thought that you have, Dr. Ali, you said that chronic disease is higher. Let me tell you one thing. WHO in 2009 flipped and stated that World Health Organization stated in 2009, until then infectious disease was the cause of major morbidity and mortality. In 2009, since 2009, WHO stated that non-communicable disease is the cause of mortality. So all-cause mortality. So now we have to decide, is cardiac disease the cause of mortality, or there are other complications of other diseases? So it's not atherosclerosis, inflammation. Now, what is inflammation and how we do go to the root cause? So basically, I will try to summarize, unless anybody has any major burning questions. I want to summarize my take on this, and I will let Dr. Nadir put a bow and tie it off. So my belief is science, is different. Science is a process, okay? It's not a belief system, okay? That's, I guess I called it a belief. Science is not a belief system, but it's a process, okay? Retractions, I think, say in this thing is a part of the process. Guidelines are part of the process. Clinical judgment is part of the process. Our job is not to defend any position. Our job is to improve outcomes, answer, and ask questions, better questions. And thank you, Dave, for asking that better question. And I was there with Dave in 2018. That journey he started in 2018, and I was there. And then he was challenged by big folks in lipidology to prove it. So he put the effort. So if you're being burnt out by the thing, why not combine? Why not ask? Why not collaborate? Why not improve? Put all this together into people process technology and help communicate, realize, implement, reevaluate, and implement the change that you want to see in healthcare. Thank you very much. Dr. Ali, please finalize and put in your comments, please.
No, thank you, Ravi. You summarized it well. And I think I cannot do any better than what you have done. So I appreciate you putting together this session. I enjoyed interacting with all colleagues from all over the world. I see people of all different backgrounds, and I really appreciate the opportunity to be here and contribute in whatever way I can. So thank you. I appreciate it. And
Yeah.
Bobby, thank you especially to you, because I kept looking at you to see whether my responses were appropriate or no, and your encouragement really helped.
Thank you. Thank you. What I'm going to add into the chat, if you guys want to do it, is so that the discussion does not die here. I'm going to add the chat that where the next follow-up is. And obviously, it is a continuous evolution, and we are all going to learn from each other. Nobody knows everything. So, we need ping balls. We need to trust each other, but also question each other. So thank you very much, guys. And it has been a pleasure. It has been a
You all
pleasure.
have a great day. Thank you. I'm going to sign off here. Take care.
Take care.
Thank you.
Thank
Bye
you.
now.
Thank you.